Important topic. This is a very important topic to all clinicians and radiologists because both of us, clinicians and radiologists, need each other's help. And as a team member, we can solve out the case. So clinical part is as much as important as radiology. And a good teamwork actually plays an important role in solving out difficult cases. So what will go forward is fundamentals of CT scan and MRI. This section will be a brief section of very basic resident-based section so that we have a brief brush up of all the basics of CT scan and MRI sequences, how to identify them. And then we'll go ahead with some clinical cases. And to see, these are the common cases in pediatrics. I'm taking up CT scan and MRI, and ultrasound is not a part of this discussion today. So it's an important tool for diagnosis. Planning and imaging needs a detail of clinical sign. So no radiologist would like to report without a clinical history. And as good as we clinician, we need to discuss with the radiologist so many times to get out, to come to conclusion of the radiological finding. And pediatric imaging has to be decided very crucially depending upon what is the clinical condition of the child, especially in the IPD setting. So coming to the basics of CT scan, we should first know what is the unit. Unit of CT scan is Hounsfield unit. So that is HU unit, or it is a marker of CT density. So how much X-ray is absorbed in tissue differentially in CT scan, that number is given by objectively as Hounsfield unit. So bone has plus 1000, that means it is more white. We speak the word of density in CT scan and intensity in MRI. So hypodense, hyperdense in CT scan, hypointense or hyperintense in MRI. So these words are very technical words. And we have the whole list of HU unit. The important part to remember here is water, that is CSF, that will look black because it has 0 Hounsfield unit. Air will look more blacker, the most black part, which is minus 1000. And bone, as we can see the skull bone, it is the most white, which is plus 1000. So let's come into the anatomy. So in the CT scan, we can see the gray matter, the white matter. We can have some feature here. Ventricles can be seen, third ventricle can be seen, cerebellum can be seen, sylvian fissure. So these are basic structures which we can see in a CT scan. So as a resident, these days everybody wants to just learn MRI. I think so in radiology also, but CT scan is very, very important. We cannot give away with this investigation, and knowing neuroanatomy and the importance of CT scan will be an important thing. So other thing which we can come up when we come up on the upper sections is the caudate, the internal capsule, which is a V-shaped structure. The pink one is a lenticular nucleus. We have some part of thalamus here, and then this is a vermis of cerebellum. So we should know in the lower sections what are the things we can see, in the upper sections what are the things we can see. Now in the lower down, this is a medial temporal lobe. This section is important to know about the herniation. Whenever the child is sick, you really want to see this section, that what is happening to the temporal lobe. Is there any early sign of herniation? Pons can be seen as a part of brainstem, fourth ventricle can be seen, cerebellum can be seen. So these are the basic structures. Like this one is the upper section, then this is a little mid section, and this is a lower section. So these three sections are important, and what anatomical structures can we see in these sections? Indications, we all know that trauma is the most important indication, and in case of critically sick, as an emergent procedure, we do a CT scan. So in trauma, fractures and bleed, these are the two things we want to see. In sickness, we want to see about herniation and bleed. The other important thing is calcification. Even on a routine OPD patients, sometimes we advise CT scan because we want to see calcification. So in neurocystic sarcosis, when you want to see that whether the lesion is calcified, you want a CT scan. In some neurodegenerative condition, we want to see calcification. And craniosynostosis is another special indication for pediatrics wherein we order CT scan. Now we all should know that when you read a report of CT scan, if you get these two images and You have to read the report also, whether it was a contrast enhanced scan or a NCCT scan. Just looking at the image and not knowing whether contrast was given or not can be fallacious sometimes. I'll come to that. So this is a normal contrast enhanced, wherein you can see the contrast inside the ventricles and the fissures. And this is a non-contrast. Now this is a contrast enhanced CT scan. And here, this is another image. So if you don't tell whether this is a non-contrast or a contrast CT scan, sometimes it can mislead. This is a case of subarachnoid hemorrhage, which looks like a contrast enhanced CT scan, but these are all bleed in the fissures. And here you can see some swelling. So it's a case of trauma with subarachnoid hemorrhage. So you should always know beforehand whether you're reading a NCCT head or a contrast enhanced CT scan. So what are the hypodense lesions in CT scan? Air, edema, fat. So this is air, which is most black. So it is even more black than the ventricle. So this is a PP shunt side, and during the shunt side, there is a air fistula, which is the most black circular thing. Then infarction, you can see a hypodense lesion in the area, in the parieto-occipital area and in the territory of the MCA territory. So then you can see a neurocystic sarcosis, again a perilesional edema, which is more black, which is hypodense. Again, you can see parieto-occipital hyperdense area, which can be a marker of breast in CT scan. So what are the hyperdense lesion? It's a bone, obviously bone, bleed and calcification. So bone, bleed, calcification, hyperdense, and other structures are more black. So this is again bleed, this is calcification. And this is again, this is GP calcification or basal ganglia calcifications. So some cases we do want to see in mineralizing angiopathy cases, the cases who have some other neurodegenerative conditions, you want to get whether they have basal ganglia calcifications, you want to see a NCCT head. So what are the common neurological conditions? One is trauma. Obviously, you can see a depressed fracture here. And here again in the 3D view, it is more clearly visible. Craniosynostosis, CT scan, again you can see there is a trigonocephaly, a metopic suture is closed, diffused. Infections. So CT scan is a very important modality for infections also. In brain abscess, very beautifully it can see a ring enhancing abscess here. And tubercular meningitis, basal exudates can be clearly seen. And in neurocystic sarcosis, very clearly, a ring enhancing lesion can be seen with a scolex. Venous sinus thrombosis. So in NCCT head, there can be a dense cord sign. That means the sagittal sinus, you can see a hyperdensity here. And when you do a contrast study, you can see an empty delta sign with some hemorrhage. Venous sinus thrombosis, they can have hemorrhagic transformation. And in some cases, you can already see a hemorrhage with this blackish thing is perilesional edema. So this one is edema. In arterial ischemic stroke, ideally, we do want to get a diffusion restriction scan as soon as possible. But even if you have a CT scan, it can sometimes give you a marker of early marker of arterial ischemic stroke. So here, what are the early signs? Loss of insular ribbon, and other thing is loss of gray-white differentiation. So between this is a normal one, this is a one wherein you have a history of acute arterial ischemic stroke. Hydrocephalus, CT scan is another important modality. And whenever you see a case of hydrocephalus, ventricles are full, you want to understand and comment on communicating. So whether it is obstructive versus communicating. So CT scan gives us the idea of the lateral ventricle, the third ventricle, the temporal horns, and here when you get down, you can see the fourth ventricle. So here the fourth ventricle is full, the third ventricle is full. It is a case of communicating hydrocephalus. In ICU settings, so herniation is very important thing because patients are not stable enough to get an MRI. So here you see a diffuse cerebral edema. Here you see right ankle herniation. Here you see what is white cerebellar sign. So supratentorial compartment, you can see more blackish. That is because of edema. And cerebellum appears white. That is called white cerebellar sign because there is a diffuse edema in the supratentorial compartment. So it is a bad prognostic marker in ICU settings. So coming to the MRI brain, MRI brain. So I'll tell you the basic sequences. Here we need to see multiple sequences in multiple depth and multiple sections because it gives us the 3D view and a clear dimensions and more clear characterization of some of the disorders. So here intensity is the word, not a density. So in CT scan, it was density. So this one is a T1 weighted image and this one is a T2. So white thing is T2. That is very easy for all of us to remember. So in T1 weighted image, gray is gray. This is a gray matter which is gray, white is white, and CSF is black. In T2, the best is the CSF is bright. And you can see the gray matter which is more whiter. The white matter is darker. So it is contrast to T1. And T2 flare, you can see here, it is again the fluid is suppressed. So flare means fluid is suppressed. It is same, almost same as T2 in terms of gray and white. So the gray is whiter, white is darker. But here CSF is suppressed to give you a better contrast picture. And again, you can see some periventricular cuffing here. That is another marker in cases of flare. So these are three basic sequences with everybody of us should remember when you and comment on. As a resident, if you are appearing for exam, you should comment on what sequence are you seeing in the scan. So why do we need a flare sequence? Because see, same thing, pathology you are looking at in T2 scan and in flare scan. In T2, you can see some periventricular white matter volume loss, some gliosis, but which is very clearly seen in this because it gives a clear contrast between the CSF and the gray and white matter, wherein you see a periventricular leukomalacia. And here it gives you the clear diagnosis. So that is why a flare sequence adds an extra edge in diagnosing cases. Now, diffusion restriction and EDC. So diffusion restriction is diffusion weighted imaging, DWI. So in the DWI, we see the whitish thing, that is the restricted. So how do we commit? So there is a diffusion restriction on the right side of frontal and the temporal area. And the same thing when you compare with ADC. Why do we get a ADC? ADC is constructed, the diffusion restriction is achieved when you get a thing which is white, like a diffusion restricted image, and you see on ADC the same area. It's a negative imprint of DWI. If you get the same area black, then it's a true restriction. Sometimes there are artifacts and the phenomena is called T2 shine through. So in that DWI, you will see the restriction, but no ADC showing up the same thing. So that means it is artifactual. T2 shine through means artifactual. So we should always see DWI and compare it with the ADC to make it sure that yes, this is a marker of cytotoxic edema and it's a true restriction. So DWI is very important, especially in acute cases. So in all ICU settings cases, we would like to see DWI, what is happening in tumor, ischemia, infection. They exhibit lower diffusion coefficients. Susceptibility weighted imaging, this sequence adds a very important information about the bleed. So these are small microbleeds. You can see some vascular prominences here and calcification, blood products. So basically blood products and calcification. These are very important sequences on that. So calcification in SWI. So in CT scan, we can see white. In SWI, we can clearly see a blackish, blackish mark, blooming. So a very important part in pediatrics, less than 2 years of age, when you comment, you want to know whether the myelination is complete or not. So these are the structures which are myelinated at birth. Dorsal brainstem, ventrolateral thalamus, posterior. So we want to see plic, very important. If you don't want to remember all this long list, just remember plic. That plic is myelinated at newborn in a full-term baby. So that means myelination is appropriate. So other things are central corona radiata, Rolandic gyri, so central corona radiata, Rolandic gyri, perirolandic regions. These are all myelinated structures. Now, progress of myelination from 0 to 2 years happens in a particular fashion. And there is an order to that. So from central to peripheral, there will be myelination. From posterior to anterior, so from back to front, there will be myelination. And from bottom to top, there will be myelination. Myelination is always seen first on T1, then on T2. So that means if you want to comment on myelination in a child who is 1.5 years old, you want to see T1. If T1 is matured for the age, but T2 lags behind, it is okay. T1 shows signal intensity a little earlier, maturity a little earlier compared to a T2 scan. So advantages, and this we all know, no ionizing radiations. The risk, especially in pediatrics, is of sedation. So whenever we think whether MRI or no MRI, sometimes we postpone getting an MRI done just for the risk of sedation, especially from 0 to 2 years of age when the child is very small. Unless until it is severely indicated, sometimes even on a OPD case, we tell, okay, we'll do it later when the child is more stable. Or if the child has some respiratory issues, we postpone it just because of the risk of sedation. So that is the important part in pediatrics. And it gives the extra edge for the posterior fossa structure for microbleeds. Angiography will give extra idea about the vascular structures. Functional imagings are also available. And what are the disadvantages? Obviously, in sick patients, we can't do it. Cost is an issue. It's time consuming. And in pediatrics, sedation is an issue. So clinical scenario, radiological evaluation. So I've divided into 4 sections. One is developmental delay, which is in pediatric neurology, the common complaints are one, delay in development, second, seizures. These are the most common. I mean, I would say 90% of the cases would come into either of these category. Headache and neuroregression is another lesser version in our OPD practice. So whenever we come to a case of delay in development, we want to understand what are the additional history and signs. So what was the history, the birth history, the family history, how was the child growing, and what is the differential in development. So it is just the motor delay or motor plus sociocognitive delay. And when you want to examine, you want to see what is about the head size. What about the dysmorphism? What about the skin, the neurocutaneous markers? Are there any birthmarks? What about the abnormalities of tone and movement? So it is not just development, you want to examine also very well to make a hypothesis or a provisional diagnosis. So now in cases, if you have a clear genetic syndrome, you can see on the face, it's a case of Down syndrome, and the child has delay in development, you will not order an MRI. You know that's a part of that genetic syndrome. If you see clearly Ashleigh macules and adenoma sebaceum, you're kind of sure on tuberous sclerosis, you will go ahead with MRI brain and you would not like to go ahead with a CT scan. If you see some boat pine stain on the face and with a neurological complaint, you want to get a CT scan, is also okay. If you are ordering an MRI, get it within contrast because it's a vascular angiomatosis. So you want to understand the vascular phenomena in these kids. So let's come to the cases. First case, this is an 8-month-old infant. The child had a right focal seizure. The child presented to us with the status epilepticus. So first event seizure and that too a status epilepticus focal. And here on examination, we see a clear port pine stain. So we had the possibility of Strach-Weber and this was a scan wherein we can see in the contrast study, the angiomatosis can be seen over the whole hemisphere. So it's a case of Strach-Weber syndrome. Now, this is another case. The case is a 15-month-old baby. He was developmentally normal. He had these kind of abnormal movements, 1 to 2 episodes per day, and it just started 7 days back. So here you can see these. So these are spasms. These are infantile spasms, wherein the child is having flexion spasm. There is no regression of milestones because it just started in last 5-7 days. Child is smiling, happy otherwise. And here, what did we get? Important clue. There was a whitish spot. So that was an ash macule here. We can see clearly on the forehead. On further examining the child, we saw that there were the same child. We had further ash macules. We had chagrin patch. We got an MRI which showed subependymal nodules, and you got an EEG which showed hypsarrhythmia. So this was a case of tuberous sclerosis with West syndrome. And here Vega pattern is the drug of choice. So that's the importance of history examination and again radiological and electrographic, that is electroclinical correlation to make a diagnosis. So what are the other features of tuberous sclerosis? Herein we can see subependymal nodules. These are the tubers. So you can see cortical tubers here and there, and you can see subependymal giant cell, basically SEGA also can be seen. So, 5-year-old child, he had developmental delay. You can see some contractures in the hand, and he's non-ambulatory. That is why he's just lying a size of head, which is very small. And here, there was no such a birth history. We ordered an MRI. MRI showed, I'm just posting a single slide, when you can see a smooth brain. So, posterior dominant smooth brain. Anterior, you can see some gyri, but these are less. So, it's a clear lesion-cephalic brain. Schizencephaly is another cortical malformation wherein you see the cleft. So open lip or closed lip schizencephaly, and the important differential is a porencephalic cyst. Sometimes you get these kind of features where you can see some gliotic cysts which are larger. So that's called porencephalic cyst. And here you can see features of gliosis. So, and in the schizencephaly open lip, you can see cortical structures very beautifully lining the cleft. So do not miss this. Sometimes it is reported as schizencephaly. Basically, porencephaly versus schizencephaly has to be correlated with history and with an MRI scan looking for gliosis around and how is the cortical tissue behaving around that area. Hemimegalencephaly is another cortical malformation where you see thick brain here with white matter getting abnormal signals. So hemimegalencephaly. Here, this is a child who is a 9-month-old child. Child is crying because child has stranger anxiety. I was clicking a picture and child was anxious. So that shows child has normal cognition and child has large head. So for a 9-month-old child, he had a large head, normal developmental milestones. Otherwise, when they did an MRI, they saw white matter which was abnormal, a leukodystrophy kind of pattern, and you see early features of cyst in the temporal area. So this is a case of megalencephalic leukoencephalopathy with subcortical cyst. Now, neurocutaneous syndrome, before going and thinking about radiology, is getting this scans done or understanding what is there in the report, you have to first see clinically. So, if a report comes that, a MRI report comes which says that can be a case of tuberous sclerosis, this should not be the way. The way should be clinicians should be suspecting that yes, by the examination, the child might have tuberous sclerosis and radiologist confirming it. So rather on the opposite way around. So importance of examination, especially in pediatrics, because these are common cases wherein you see macules, adenomas fascium, the facial plaque, excessive Mongolian spots that's seen in Tay-Sachs disease, the Sjogren patch. So dysmorphism, I'll not teach the whole part of dysmorphism, but then clearly you can see that the face is little odd than our racial features. The Caucasians, the Indian racial feature is different, and you can really see that there is some abnormality here. This is a clear case of Down syndrome. This child was a mucopolysaccharidosis. This is a case of Fragile X syndrome. This case was actually PACS2 mutation positive. So dysmorphism. So basically the idea is when you see a child who has global developmental delay, some features of dysmorphism, rethink whether you want to get an MRI done or not. So if you have abnormal signs means what? You have abnormal tone, posture, abnormal movement. These are also a part along with the development you want to suspect for cerebral palsy. It is again a very common and spectrum in pediatric age group. The reasons can be any hypoxia, hypoglycemia, connectorosis, hyperbilirubinemia, that is bilirubin-induced neurological dysfunction, and prematurity. These are the 4 very common reasons why a child can have cerebral palsy. And MRI is advised if child is sick or is not, there is no urgency, like in case of seizures or status, we sometimes postpone MRI in these kids till 2 years of age. So the myelination is also complete and child is stable enough for sedation. So this is a HIE is hypoxic-ischemic encephalopathy. A 5-month-old child, he had a history of perinatal hypoxia. He presented with small head. You can see a hairpin kind of thing. The cranial synostosis also you can see. And this was MRI. So cystic encephalomalacia was there in the MRI. So that's a clear marker of perinatal hypoxia. Here, this child is 2.5 years old and he had history of global developmental delay. He had scissoring when the child started to sit and was trying to walk. So there is clear scissoring. That is a feature of spasticity. in this child, and when you did an MRI, you saw periventricular leukomalacia. So periventricular area, that's PVA, is a common radiological finding in a child who has prematurity, and they can present with spastic diplegia or spastic paraplegia. Now, this child was sick, was admitted. You can clearly see opisthotonous generalized rigidity, and the child had history of developmental delay in the background. And on taking history, child also had a history of perinatal asphyxia, delayed cry, admitted in ICU for some time. When we did an MRI, you see the posterior putamen bilateral, there are hyperintense signals, and this thalamus also you can see hyperintense signals. So this pattern of putamen and thalamus hyperintense signals is seen in a case of term child having history of hypoxia. So sometimes we call as term HIE. And mind it, clinically, I see so many cases wherein history fits in, but MRI was reported normal. So that means these subtle findings are sometimes missed even by some radiologists who are not trained to see putamen and thalamus in a child who has hypoxia. So this is a whole spectrum of hypoxic ischemic encephalopathy. The expected MRI findings. First is a PVL, that is white matter paucity and leukomalacia. Cystic encephalomalacia. This is again posterior putamen and thalamus, that is term HIE. Here, the parieto-occipital gliosis. So whenever you see this MRI in a small child, always look for the history of hypoglycemia in the neonatal period. So look into the paper. As a clinician, we should, leadingly ask whether there was a history of hypoglycemia in the neonatal period and the child was admitted. Here, this is globus pallidus hyperintensity. So this is a radiological marker of bilirubin and in the neonatal period. So that is connectress. So these are the 5 common MRI spectrum of radiological finding in HIE. So seizures. In cases of just epilepsy, we want to see whether we want to evaluate and we order for an MRI. Now you got an MRI done, you got a ring enhancing lesion. We want to understand it is NCC or tuberculosis. There are certain findings wherein we understand. So here everybody of us can see a lesion and a perilesional edema. This one is a T1 scan where edema is seen, and here we can clearly see scolex. So if you can see scolex clearly in a FLAIR image, and you can be sure that this is NCC. In tuberculosis, if you see T1, maybe mostly you will see nothing. So this same scan, you can see almost like nothing here. In T2, you can see some scan where in the core is hypo. So hypo intense core. So we want to understand what is the core. If it is hypointense, it goes in the favor of TB. So learn this word, hypointense core with hyperintense rim is a marker of, in T2 images, it's a marker of tuberculosis. So this is a whole list of TB and NCC. So what we can see in TB is a gray white matter differentiation. Here it is seen in circle subarachnoid space. T2 caseous granuloma, hypointense. So hypointensity means caseous granulotosis, that is necrosis. And in T2 hyperintense because unless it is calcified, it is hyperintense. So the cyst has its own fluid, it is hyperintense. No or incomplete suppression on flare, and it has complete suppression of flare. So flare, this was a flare image, complete suppression. So you can see suppression of the core that is seen in NCC, and it is not a complete suppression in TB. Scolex is seen in NCC, and it is not. So size also gives sometimes idea, conglomerate lesion, and additional finding. If you have meningeal enhancement around, obviously you'll go ahead with tuberculosis. And then finally, this has to be correlated clinically also. So other common thing in a child who is sometimes admitted, or they might come in the OPD also with a history of fever, headache, long history, and then you see they have additional complaints, evolving complaints of vomiting and altered sensorium. So this child was admitted in our ICU, and the child had, here we can see ventricular fullness, the temporal horns which is dilated, some ooze around the ventricles, and when you did the contrast study, the basal exudates are clearly seen. So this is a clear case of tubercular meningitis. 7-month-old infant, history of fever, altered sensorium for 5 days. And day 6, the child had further complication. The right eye ptosis and the pupils were dilated and imaging was done. So here you can see the feature of cerebritis. So for overall, there is a meningeal enhancement, but then focal cerebritis is seen, diffusion restriction is seen over left frontal area. The same is seen here, and there is some bleed also in that. So this was a case of pneumococcal meningitis, and the child also had 6 nerves. So here you can see the vascular. So the child also had cranial neuritis along with that. So cerebritis, cranial neuritis in the case of Streptococcus pneumoniae. So 9-year-old boy, he had fever for 2 days. He had paraparesis and urinary retention. On scan, you got a hyperintense lesion on T2. Very subtly it is seen here on T2 dorsal MRI. And here you can see more than 3 segments. So it is important when you see a scan for myelitis, that is the cord getting affected, how much vertebra, how many vertebrae are they causing? 1, 2, 3. More than 3 vertebra contiguously, if you are able to see hyperintensity in the scan, it is called longitudinally extensive transverse myelitis, LETM. There is importance to it because if there is LETM, you would suspect about NMO disorder, NMOSD or NMO illness, that is neuromyelitis optica. So that is again equaporinopathy. So equaporin is around ventricles. These are the places where you expect aquaporin receptors to be there, and in these disorders, these are the areas where you see hyperintensity. So periventricular area, periaqueductal area, periependymal area, around the ventricles. So periaqueductal, periependymal area are the favorite places, and you see a scan with these findings, you suspect that probably the child might have NMOSD. So in cases of neuroregression, MRI also helps us. He's a 13-year-old boy. He had history of frequent falls, and you can see the child is having negative myoclonus. He loses the balance, and he also has abnormal grin. There was nothing to smile and grin, and so that means he also has emotional lability. I've just hidden the face. You saw negative myoclonus. He lost his tone, and he was having these kind of features with falls. And he had ataxia for 7 days. So progressive symptoms over 30 days. So gradual cognitive decline as well. So suspected case of SSP. So progressive myoclonic epilepsy was a differential diagnosis, and SSP was suspected. We got an MRI and we got this. So bilateral posterior hyperintensity, and you can see some preservation of subcortical EO fibers. In MRI, when we see a diffuse hyperintensity or a leukodystrophy kind of pattern, the pattern recognition gives the idea. It is posterior or interior, what other fibers are involved, what structures are involved. Here, this was a posterior dominant leukodystrophy, so very important differential for adrenal leukodystrophy also. So SSP clinically is a very what to say, this MRI can be the presentation finding of 2 disorders, that is SSP as in our case, but the other differential, very strong differential, is adrenal leukodystrophy. They also have this pattern. So only MRI. If you just see the MRI, you cannot make out the diagnosis unless you correlate clinically whether it is ALD or it is SSP. And then in ALD, we do a contrast study. You can see a contrast, a peripheral contrast enhancement, which is a marker for ALD. So another case, it's a case of ataxia. It's a 5-year-old girl. The child had motor regression, and on examination, the child had very red eyes. So this was telangiectasia. And when we did an MRI scan, the child already had ataxia. We expected cerebellum to be affected. And the cerebellum shows the child had cerebellar atrophy. So, the telangiectasia and atrophy, it goes in the favor of axia telangiectasia. So summarizing the cases, summarizing according to symptomatology, what MRI to be investigated. MRI, if the child has fever, acute or subacute onset, neurological features, obviously MRI brain with contrast when you suspect any infection or inflammation. When you have chronic neurological symptom like developmental delay, subtle ataxia, some postural disturbances, only plain MRI can do. If you have epilepsy, MRI brain with epilepsy protocol is a good idea. If you have neuroregression, you want to get ahead with the white matter and the gray matter, MRI brain is required. But then if clinical suspicion of leukodystrophy is there, do get an contrast scan. If you have a case who is like a primary headache disorder, migraine, so no neuroimaging unless until it is clinically indicated or a acute onset severe headache is there. If you clearly have a history of recurrent episodic headache which fits into migraine, you did not get MRI at a first go. And neurobehavioral disorders, if the child has autistic features, ADHD features, no other neurological features, imaging is not mandate in these kids. Now, according to etiology, if it is congenital problem, MRI is required. Traumatic, if it is an old insult, there's a history of trauma and now you are getting some features, it's MRI brain. Acute trauma, CT scan. Infection, inflammation with the contrast in MRI brain. And any vascular pathology, you want to decide on venography versus angiography. So these are the basic sequences or the basic imaging which we order in OPD. Now, again, just recapitalizing, CT scan for trauma, craniosynostosis, for hemorrhage, for sick child, MRI in situations, practically every situation where CT scan is not required, epilepsy protocol when you suspect a case of MTS, contrast study, infection, demyelination, tumor, SOL, contrast study is required, angiography if vascular phenomena is suspected, venography if you are suspecting any venous pathology. So here there is a caution. Situations can be tricky. It is not just as simple as we discussed in the table. When the radiology do not match the clinical suspicion, you suspected something else, imaging came out to be something else. So sometimes the appropriate sequence is not taken. So in that cases, you should discuss with the radiologist and decide whether we did a right job, do we need some other scans or to delineate the finding. So discussion in team with the radiology is an important role. Correlate clinically also. Radiological mimics are known. As I showed the case of posterior dominant leukodystrophy, ALD or SSP, both cases are totally different with the same radiological picture. So role of clinicians is to rule out the mimickers, the radiological mimickers to make them fit into clinical finding. So a 14-year-old boy, fever for 30 days, no clear localization. All the scans were done initially when normal. CT scan just had mild ventricular prominence. And CSF was done, we showed Mycobacterium tuberculosis. So kind of this matches the history that the child has long history of fever and CSF showed MTB. But when the MRI brain was done, it was totally normal. Now there was a thing that how the MRI can be normal, the CT scan showed prominence. But why there is a confusion? Because the image was a non-contrast MRI. Sometimes if we don't give a contrast, we are not able to see basal exudates or the early tuberculosis, the miliary findings, which can be just picked up in a contrast scan. The MRI brain can be totally normal. So here it is not that it is not matching. We did not do a right scan here. You have to first do the right scan. So get a contrast MRI done and it shows meningeal enhancement. So this completes the whole case to be a case of TB meningitis. So clinical evaluation is must. Provisional diagnosis should be attempted. Planning of imaging modality is important, not just getting MRI done for every case. You have to decide in your mind what you want from the scan, and discussing with the radiologist is the final step for difficult cases. Thank you all for the patience. So I would be happy to take some questions. Hello. 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 Hello.
You are audible. You are audible.
Oh, yeah. So I finished my scan and I would like you all to give some.
So my observation is I have learned a lot. I have revised all. You, in fact, you have really made it easy, as you said. But
Thank you.
in the end, I'll still say it is not easy. It is practice, practice, practice. You have to always. I am a clinician of an era when there were no investigation. So I still say you have also highlighted. Even today, the clinical findings are relevant. Often you are not able to make a diagnosis with only imaging, or never able to make a diagnosis only with imaging. So you have highlighted every aspect. I also would like participants to ask question if there are any. There are still, I think, 10 more minutes are there. So let people ask you question. For me, it has been a good learning, good revision of since the time you are with us. I don't delve into much of pediatric neurology except some seizure disorder or some follow-up patient which I am taking, but you are excellent. So I compliment you and I compliment people who are there present and learning. Thank you.
Thank you, sir. Dr. Shashank, are you here?
Yes. Good
Yeah.
evening, everyone. So, ma'am,
Yes,
I must say
even
that,
more inputs.
hello,
Uh-huh,
am I
yeah,
audible, ma'am?
yeah,
Uh,
audible.
uh, I must say, ma'am, that it was actually a wonderful lecture. You have covered the basics of CTMR as well as you have shown interesting cases.
Mm.
Uh, I would highlight a few points as far as radiology is concerned. So, as we all know that neonatal brain, especially neonates and infants, the brain is very different as compared to that of an adult brain. Why?
Mm.
Because the white matter is unmyelinated. So we have more volume of extracellular space in which we have more water molecules. So overall, a neonatal brain has more water content. So it looks very different on routine MRI sequences as compared to that of an adult brain. Therefore, cases like dysmyelination or hypomyelination, it can become very tricky in diagnosing on MR. And as you pointed out, ma'am, that in perinatal hypoxic-ischemic insult, the imaging pattern, the findings that we see on MR is quite different from that of an adult hypoxic injury. So depending on the severity of insult, what was the duration of insult, and the brain maturity, right? Whether it is a preterm baby or a term baby, imaging can be quite different, and findings can be missed, as you rightly pointed out. Then I'm coming to the epilepsy imaging. If we have gross pathologies like say a tumor or heavy megaencephaly or Sturge-Weber, so that can be picked up quite easily. But many times we have small cortical malformations like a polymicrogyria or focal cortical
Mm.
dysplasia involving a single gyrus. So in that case, again, findings can be missed. So the ILA, that is the International League Against Epilepsy, has recommended harness MRI protocol. So I think every
Mm.
clinician must ask the radiology department to get harness MRI protocol done if the previous MRI findings suggest it is normal. So it is also recommended that a radiologist should spend at least 10 to 15 minutes on a given MRI in epilepsy patients before labeling it as normal. So in that case, I guess the harness MRI protocol is of utmost importance. Then again, ma'am, you showed a case of NCC. Then it's a century-old diagnostic conundrum, I guess, NCC versus tuberculoma. But I must say that if we combine the conventional imaging with some advanced sequences like MR spectroscopy or magnetization transfer imaging, so in 90 to 95% of cases, I think confidently we can say that it is a tuberculoma or NCC.
Mm.
It was, I think it was a wonderful lecture, and there are many other these diagnostic dilemmas. I think we can resolve with robust clinical radiological discussions. Yes.
So do you always recommend the MTR sequence or MR spectroscopy wherein you kind of get fixed between NCC versus TB?
Yes, ma'am. So, if with conventional imaging, that is T2, 3D cis, contrast, if there are very specific findings, then no need to go ahead with MR spectroscopy or MTR imaging. But if there are many cases, like in 10, 20, 30% of cases, actually it becomes very difficult just on the basis of conventional imaging, then in that scenario, we go ahead with MR spectroscopy is the least thing that we go ahead with. If the machines have MTR, that is magnetizing transfer imaging, then we go ahead with that as well.
Okay. Sometimes I've seen false positive cases also, that even on
Uh,
NCC
yes,
cases, see
yes,
lipid gastric peak. It,
right. Yes, that happens, ma'am.
okay.
Because the lipid peak can be seen in NCC cases also, rarely. But again, we have to see the lipid height. What is the height of the lipid peak that we are getting? So that is actually on the higher side in cases of tuberculomas.
Mm-hmm. Okay. So good learning points, Shashank. So especially neonatal brain, I would say clinically also, even I, after so many years also, sometimes I get fixed and come to you to discuss that what's there.
Right.
These are very special MRIs. Less than 2 year MRIs, I think less than 1 year specifically. More than 1 year is
Less than
not
1 year, exactly. Yeah.
problem. Less than 1 year MRI about myelination, it's a difficult task to actually.
Yes, ma'am. So in less than 1 year, there are three sequences that we have to look: T2, diffusion, and T1. So these are three important sequences. So there is no role of flare in less than 1 year because the brain already has a lot of water. So
Yeah.
flare usually helps in detecting water whenever there is edema, cytotoxic edema or vasogenic edema. So that is quite evident on flare. But because the normal neonatal or infantile brain has a large amount of water, then flare goes out of the picture. So there's no importance of flare in infantile brain.
So good learning point again. And we have some questions also here. So MRIs required for differentiation versus NCC, I think so you cleared it. At
Yeah,
what
we have already
age
discussed
MRI to
it.
be done for asphyxia child? So here the answer is not, there's no particular age. Say if a 7-month-old child starts to have West syndrome, have to have spasm, and there was a history of hypoxia, you may go ahead with the treatment if there is no other differential. If there is a case of diagnostic dilemma, no clear history of hypoxia, and the kind of clinical picture doesn't match, you have to go ahead with the MRI at that time only at 7 months, but then with the risk of sedation. You have to explain because they have to go ahead with sedation. The only idea of not getting an MRI or postponing MRI, it is not getting is, it is postponing MRI for the risk of sedation. If the child is otherwise well, it is when the child requires it. If there is no mandate, the child just has developmental delay and you can see microcephaly, you can see tone abnormality, you can suspect the case as CP and go ahead with just rehabilitation rather than getting a scan done immediately. Difference between brain abscess and a ring enhancing lesion. So there's a question, Dr. Shashank, you would like to answer on this?
Yes, ma'am. So I'd like to add a point to the previous question about the timing of imaging. So if we are dealing with a perinatal asphyxia, so as far as imaging is concerned, we go ahead with ultrasound cranium initially. But as far as MRI is concerned, so day 4 to 5 is considered to be the ideal time after the hypoxic event, because so initially when there is hypoxia, so we only have one sequence, that is DWI, in which we can pick up the injury. But on day 4 to 5, the hypoxic changes become quite evident on T1 weighted images also. So at that point of time, we have two sequences that can help us in delineating the extent of brain injury. So it is said that day 4 to 5 is the ideal time for doing the imaging for perinatal HII. Uh, so the next question is differentiating difference between brain abscess and ring enhancing lesions. So the ring enhancing lesions, we have a lot of differentials for that. One of the differential of ring enhancing is like a peripherally enhancing lesion. One of the differential is brain abscess. So the brain abscess will have intense diffusion restriction, whereas a ring enhancing like tuberculoma or NCC won't restrict. Only a few stages of NCC like the colloid vesicular stage can show mild restriction, or we can say the liquid chelating stage of tuberculoma can show restriction, but the extent of restriction is quite too much in brain abscess as compared to the rest of the ring enhancing. So we have other causes of ring enhancing lesions also. I think it's a broad question, but overall, if you say that if you're dealing with brain abscess, then the restriction is going to help us, diffusion restriction.
Yeah, so true. Do we have any other question in house? Dr. Ritika, we don't have much questions, I think so.
Yes, so I think we've answered all the questions that were there in the chat box. Thank you so much, Dr. Rajni, for conducting this really very informative session. And thank you so much to our panelists, Dr. Rajiv Anand sir and Dr. Shashank Raj. I have a few announcements to make. So, our next telepede session will be 2 weeks from now, and the topic for that will be announced soon. It is also my pleasure to announce that we are conducting our 9th annual pediatric update on the 29th of June at JP Siddhartha Hotel. It's a Sunday, and we'll be covering almost all relevant topics in pediatrics, from all subspecialties. We'll be having few panel discussions and some talks from eminent specialists here from our team at Center for Child Health in BLK Max. I um, uh, invite you all and request everyone to please attend this meeting. This will be a physical meeting, it's not an online meeting. Um, I would also like to thank all the participants who could take out time on a busy day from their OPTs to attend this session. And we'll be coming with a new session 2 weeks from now. Thank you so much. Have a very nice day.
Dr. Ritika, somebody wants to know about further classes of telepeds. So I think so we can communicate to them personally also. We can note their numbers.
So
Dr. Ritika has answered on this.
we usually announce these teleped sessions on the important on all the IAP WhatsApp groups. But whoever wants to know can we usually conduct them on second Thursdays of every month, and the recordings are available on YouTube on the BLK Pediatric Practice YouTube channel, so they can always be accessed. These meetings are almost set at second Thursday of every month. So, anything else that the delegates would want to know? All recordings also.
No, I think the recordings are also there. They can
Yeah,
even
I think
access later
so.
also. And the
So
previous
Vipul
meetings
has
also.
given the link for from where they can access these recordings. All right. Thank you so much. Thank you so much to all the delegates.